Let's begin Chapter 6, our chapter on trauma and stress. We'll start with two basic terms, stress and stressors. A stressor is anything that basically threatens to rock your boat, anything that threatens your peaceful existence, from maybe momentarily losing your keys to very significant life stressors, including some of the ones pictured. Before we go on, let's just take a moment and list maybe 10 stressors in your life. Does not have to be any significant ones. Hopefully you'll be willing to share maybe a one or two if this is a live class. But let's take a moment. You might be surprised to see how many people around you have exactly the same stressors. Now the term stress refers to both our body's psychological and physiological reactions to these events. Let's now consider stress in the body, and let's see what you remember from intro psych. Of course, we'll have to focus on our fight or flight response. So take a moment and look at the blanks on this slide and see how many of them you can fill out before you actually listen to the narration. So the HPA axis stands for hypothalamus, or if you want to be fancy, hypothalamic. P is for pituitary, and A would be for your adrenals, so the HPA axis. Now perhaps you remember that there are two basic branches of the nervous system, central and peripheral. The peripheral branches include the autonomic nervous system. That is subdivided into two branches, and one of them is the stress and emergency branch. And perhaps you remember, or not, the sympathetic branch. Now if you consider the gland that begins with A, the adrenal gland, it makes hormones including adrenaline and cortisol. In acute stress disorder and post-traumatic stress disorder, both of them involve overactivity of a particular neurotransmitter, and also acts as a hormone depending on where it is in the body, norepinephrine and cortisol. Let's now consider ASD and PTSD. Now I know everyone knows PTSD is post-traumatic stress disorder, but ASD, people are less familiar with that one. That would be, of course, from our previous slide, acute stress disorder. Both of them first appeared in DSM-3 back in 1980. Interestingly, another very famous dissociative disorder also made its appearance in that DSM and in that year. Both ASD and PTSD are psychological and physiological reactions caused by traumas. ASD and PTSD are highly similar disorders. The difference is the amount of time the disorder has been presenting itself. For ASD, the symptoms must last between 3 days, that is, it can't be diagnosed on the first day after the trauma or the second day. So 3 days up until 1 month. At 1 month, that diagnosis would no longer be appropriate. So then, what would be the time period for PTSD? If you're thinking 1 month, exactly, 1 month or after the trauma. But it's interesting to note that for approximately 25%, that is a quarter of PTSD cases, symptoms do not become full-blown until 6 months after the trauma. Let's now consider the diagnostic criteria used for diagnosis. Some will need to be present, but certainly not all. First, of course, would be exposure to a trauma. Now this can be direct or indirect. So the event might have happened to the person. The person might have witnessed it. For example, maybe you stop at a car accident to help. It could also be that you're a professional involved. Maybe you're a EMT driver, a fireman or woman, a therapist, a medical technician. So you are directly involved in working with that individual, and you can be traumatized either by directly working with them or the descriptions that they provide. It is also acceptable to diagnose it if it's been told to them by a family member, a close family member. So it would not be appropriate to diagnose it if somebody's traumatized by listening to the hardships faced by people in Ukraine right now. But if it was a first-degree relative, maybe a sibling over there fighting, for example, then it could be appropriate diagnosis. The person would re-experience the event. Take a moment and think of the various ways it might be possible to re-experience the event over and over. Typically what comes to mind first for most students would be flashbacks, but not essential to be there and not even typically there. It might just be trigger events in the environment, a sound, a smell, the way the wind is blowing. Maybe it went just like that before the tornado hit. It could be memories. It could be dreams. So re-experiencing the event over and over. Hypervigilance, always scanning the environment for threat, looking for a way out, looking for a shelter, jumping at the slightest noise. Avoidance of factors related to the trauma, the location, the topic, so avoidance in all manner possible. It will impact how the person thinks. They might blame themselves. They might think all people are terrible. They might think they have caused it. They might have impaired thinking, concentration, and so on. It could also definitely affect the mood, either no ability to feel pleasure, feeling very negative, not ability to feel anything at all. Sleep issues, of course, very common, and it would definitely have significant distress or impairment as being an essential feature. Let's now consider causal event and risk factors. Take a moment and list in your notes as many different categories of causes as you can. Go ahead and actually do it, please. So natural disasters such as flood, wildfires, tornadoes, hurricanes, tsunamis, volcanoes, obviously not all those in our regions. Assault could be a violent robbery, it could be rape, it could be torture, it could be domestic violence, it could be child abuse. Chronic danger, such as experiencing people that live in war zones, or maybe parts of an inner city that are so dangerous it almost seems like a war zone. Severe injury or severe pain, almost dying. As we know, it can have indirect causes, such as the stress experienced by first responders or therapists, or somebody who is directly talked to that person, a close relative who learns all the details. Lack of social support is a key determiner of who develops PTSD and who does not. Studies indicate that about a third of the risk is genetic. Apparently that person possesses a faulty gene related to their serotonin neurotransmitter system. ACEs, or current poverty, is also a risk. Take a moment and see if you're familiar with the term ACEs, if you can figure out what that acronym stands for. It's okay if you can't, but let's give it a try, just in case you had it in a previous class. So ACEs stand for adverse, so you said child or childhood. It would be childhood, and ew, that's a toughie too. Events or experiences? It'd be experiences. So adverse childhood experiences. That includes child abuse, poverty, homelessness, neglect, bullying, and many other factors as well. These would definitely predispose a person to, as an adult, acute stress disorder or PTSD. let's now consider treatment of ASD and PTSD, but take a moment. Again, what does ASD stand for? Hopefully you're yelling out in your mind, acute stress disorder. Biological treatments include antidepressants, which are often very useful in conjunction with psychological therapies. In terms of psychological therapies, the gold standard is exposure, exposure, exposure. No, we're not going to drive you to the nearest tornado or flood, but re-experiencing the event through visualizing it, talking about it, films of it, virtual reality glasses, take your pick. But a normal person, when traumatized, tries to avoid cues associated with the trauma at all costs, and that actually keeps the trauma going. CBT, particularly mindfulness training and or dialectical therapy, very useful. And possibly in conjunction with EMDR. Take a moment, see if you know any of those letters. Eye movement desensitization reprocessing. So basically the person thinks about the event and moves their eyes back and forth, back and forth, back and forth while thinking about the event. Controlled studies indicate that it is an effective treatment. In all honesty, we don't understand the mechanisms of its working. Some clinicians just think it's just the exposure aspect and the eye movement has nothing to do with it. Future studies will tell more, but at this point, it works and it's not harmful, so that's all we really need to know at this level of course. I do want to say something about prevention. Although it's not discussed in your textbook, there is research out there suggesting a possible way to prevent, or at least lessen your chances of PTSD. When you sleep at night, as you probably know from intro psych, your memories are processed, they're consolidated, they're created. Severe interruption with sleep can interfere with the processing, which is why sleep deprivation is such a bad idea when studying. But in any way, after trauma, if a person does not sleep for approximately 24 hours, the processing, specifically the emotional processing event, will be much less significant and will actually decrease significantly their chance of PTSD. Although I can't recommend it, I can tell you absolutely positively that I would recommend it to a friend or family member or use this technique myself. It's not guaranteed to work, but it'll take a little bit of the teeth out of it and maybe help you to avoid PTSD altogether. Let's now consider a disorder which your text authors decide not to include. It's not possible to include all disorders in a book this size. You'd have to have at least 30% more, if not more, added to the text. But still, I found the omission of this particularly surprising, given the fact, as you can see in the second bullet, up to 20% of people seeking therapy, up to 20% of them, the primary reason why they're seeking therapy is adjustment disorder. If a therapist works 5 days a week, they can have typically a full day's worth of clients with adjustment disorder. So even though your texts decide to skip it, we can't. What is it? Well, it has to occur within 3 months of a stressor. And one of two conditions have to occur for diagnosis. Either the person has marked distress way out of proportion to the stressor, hence the picture. If you were distraught when your dog or cat died, many people are significantly distressed. It's like a member of the family, or for many people, they're not like a member of the family, they are a member of the family. So significant distress would be appropriate. But let's say your canary died. Or if you love your canary or bird extremely, how about your pet iguana died? You probably shouldn't be severely distressed. It shouldn't impair your functioning at job, school, work. So one possible reason for diagnosis is the out of proportion of the distress. Well, the other one that you have to have would be significant distress or impairment. So maybe it is a significant distressor, but still that significant distressor, which is not related to PTSD, that significant distressor is causing, obviously the significant distress is mentioned, or impairment. Take a moment and see if you can think of examples of the first type and the second type of adjustment disorder noted above. So just for a couple examples of maybe the out of proportion, if you had dated somebody for 2 years and broke up and were significantly distressed, that's understandable. But what if you've been only on 2 dates and aren't that distressed? Well, that's probably out of proportion. Let's say that you wanted to get the best score on the tests, but you still got an A+, but there were 2 other A+, and you were third on line. Having significant distress or impairment would be out of proportion. Or about real conditions that would distress most people severely. Again, can involve PTSD and should involve grief, because that can go into grief disorder. But it could be loss of a job, loss of a relationship, loss of a house, homelessness, having to move when you really just love where you are. All sorts of things that would cause most people to have distress. Now, treatment, well, psychotherapy, of course, depending on the nature of the individual and the person, sometimes individual. It may be family would be desirable, combined with it or alone, or perhaps group therapy. Anti-anxiety drugs can be used. Anti-anxiety drugs, again, should typically only be used for a week or 2, or maybe 3 at the most. But sometimes they're useful when therapy begins, because therapy is not going to make you feel significantly better in maybe a session or 2. So it might allow you to adjust and take away some of the distraught feelings. Antidepressants will often take several weeks to work, but they're often a very good option. Hopefully combined with psychotherapy, of course. Now let's turn our focus to the second component of this chapter, the dissociative disorders. They all involve dissociation, in other words, a separation of normal cognitive functioning. So it could be consciousness, it could be a memory, and or identity. They're often trauma associated, hence their inclusion in this particular chapter. The person with these disorders often lacks symptoms of stress and anxiety. We'll consider 3 main types of disorder: dissociative amnesia, depersonalization and the related derealization disorder, and the famous one, dissociative identity disorder. Let's first start our discussion with dissociative amnesia. Depending on the variety, it's a sudden loss of the person's identity. They don't know who they are. They can't put a name to themselves. They don't know where they live, where they grow up, or if they're going to school. Loss of personal information. They could still take a test and do as well as they normally would have, but just the name and perhaps the second number would be difficult, or virtually impossible. Time period, often associated with a trauma. You can't remember the general time period of the accident. You can't remember the general time period of the bombing. Or it may be a specific event. So you can remember everything but just the specific event you cannot remember. It cannot be medical. So if you're in a car accident and the EMT asks you who's present and what's your name, and you can't answer those, well, that wouldn't be dissociative amnesia. You probably have a concussion. The recovery from these is often very abrupt and often total, and it will typically cause significant distress or impairment to the individual. The DSM-5 TR notes 3 basic forms. One is selective. That involves just the specific event, the car accident, the ship sinking, the what have you. So just the event. Continuous, it's from that event, that stressful event, going forward into the future, to the present moment. So you know the current moment, and you know things before the trauma, but everything from the trauma up until the current moment is lost. And as time progresses, the next hour, the next hour, the next hour, the next day, again, that continuing time will get lost until the event stops. Now, fugue is an interesting one. Fugue involves travel. So the person in their amnesic episode might take a trip for the day and have no idea where they were and what they did. Or it can last days or weeks, or in extreme cases, years. In some forms, the person creates a new identity and a new history. Believe it or not, sometimes there may be something in the newspaper, have you seen, or on the TV, have you seen this person? And somebody realizes them as them. And they're taken back to their old lives, and often they stay connected with their current life, or sometimes it happens again. Obviously, if that happens, they need a medical alert necklace on them at all times, or bracelet, hopefully both. Explanations? Well, there are various explanations, but earlier DSM spoke actively about Freudian theory. 2 blanks here. See if you can figure out what should go in the 2 blanks, and then we'll conclude this particular slide. So in terms of the name of Freud's theory, you could go with psychodynamic or psychoanalytic. You can't do psychosocial because that was Erik Erikson, his student. You can't go with psychosexual because that's the specific 5-stage theory with the Oedipus and Electra complex. So again, psychodynamic, or if you prefer, psychoanalytic, and particularly the defense mechanism of pushing things out of awareness. And hopefully you are tempted by repression, which would be the answer. Let's now consider 2 related disorders, depersonalization disorder and derealization disorder. These are not rare disorders, in fact, are the most common of the dissociative disorder family. The key feature is feeling unrealness of either self, as in depersonalization disorder, or the surrounding environment, as in derealization disorder. In terms of age of onset, almost always prior to age 25, childhood onset is often the norm if it does occur. For both of these, the person would have a distorted sense of time, where something that might seem to take minutes might take much longer, or something that was hours might seem to flash by. In depersonalization disorder, the bodily appearance is often strange to you. You look in the mirror and it doesn't seem like it's you, or maybe parts seem distorted. You might almost feel like you're observing yourself from a different vantage point, however that's possible. You might not seem real to yourself, maybe ghost-like, or just not real. If it's environmental aspects in derealization, people might seem mechanical, or not even real, or not even alive. Even though the person knows they're alive, they just don't feel alive. So again, unrealness of self, depersonalization disorder; unrealness of environment, derealization disorder. Now let's consider a very famous mental illness, and by far the most well-known of the dissociative disorders, currently referred to as dissociative identity disorder, though few people, unless they've taken a psychology course, know it by that name. Do you know the previous name? If you're saying multiple personality disorder, indeed you're correct. Personally, I greatly appreciate the renaming of this because it's confusing that when it was called multiple personality disorder, it implies it was a personality disorder, and yet it was not in the category of personality disorders at all. It's always been a dissociative disorder. So imagine a teacher who asks this, maybe an intro psych student, to name 2 personality disorders, which I sometimes did, and I would have to mark them wrong if they put multiple personality disorder, which students often found quite upsetting because it has the term personality in its name. Sounds like almost a Bud Abbott and Lou Costello routine if you're familiar with those old comedians. It, along with PTSD, first appeared in the DSM-3 in 1980. In terms of background, most people with it are highly hypnotizable and typically report horrific abuse, either childhood abuse or wartime trauma, but that would be a typical background. The person would have 2 or more personalities. Could be 2, could be 82. That has been actually in recorded literature. They may be fully fleshed out, fully formed personalities, or kind of shadowy, less than full personalities. They can be of different ages, different genders, different as different can be. The person with this will always have gaps in recall, presumably where the other personality, the alters are called, was at the forefront. There's different patterns where the alters might know each other, alters might know some of the alters, but not all. The alters might know the main personality, but until therapy, the main personality would never know of the alters. The person will have significant distress or impairment, especially related to the gaps in time. People constantly calling you by the wrong name, maybe getting fired from a job and you just don't understand why, bills that are attributed to you, just all these confusing events, because other people are sometimes at the forefront of your experience. Take a moment and see if you can think of any famous examples in the literature. And many have been made into books and or movies. The most famous example of dissociative identity disorder would be Sybil. Sally Field, pictured below, played her. Three Faces of Eve was another book I read back in college. I found that very interesting. Obviously, Eve had 3 personalities. One that I'll confess that I didn't read was called When Rabbit Howls. Rabbit was one of the personalities. I would like you to know that it is a diagnostic controversy in terms of if this is a real disorder or not. So we'll consider the next slide. So let's consider if dissociative identity disorder is a real disorder or one created accidentally or perhaps even intentionally by some unethical therapists. In the book Still Exposed, consider the letter included written by Silver herself, whose actual name was Shirley Mason. At one point she wrote to her therapist admitting, "I do not really have multiple personalities. I do not even have a double. I am all of them. I've been lying in my pretense of them." Her therapist dismissed the letter. So we have one piece of evidence supporting the idea that it was a created disorder. In the previous slide, you saw various handwritings of alters of a person diagnosed with dissociative identity disorder. You might say, the handwriting is so massively different. Isn't that proof? Yes and no. At first glance, it's proof. But if you have a handwriting expert analyze handwriting for maybe a child that's supposedly written by a 6-year-old or a 9-year-old, the therapist, the expert will say, this is not how a 6-year-old writes. If it was her as a 6-year-old, this is not how a 9-year-old would actually be writing. So although at first glance it would support the idea that there are different personalities, analysis would give you a different conclusion. Now let's continue momentarily. So people with dissociative identity disorder are universally highly hypnotizable. And you might say, so what? But hopefully from intro psych you know that memory is a delicate thing, and in hypnosis memories can be altered, which is why we, for example, don't allow hypnosis in a courtroom situation. And in intro psych, I always tell my students that even the existence of hypnosis itself is not agreed on by all people in the scientific establishment. So it could be an example of self-hypnosis that's accidental or even intentional therapeutic hypnosis, creating it. Different alters have different abilities. Maybe one can drive, one can type. That would lend credibility to the idea of a real, actual DID condition. Different EEGs. Again, that would support DID being a real disorder. The people have different tastes in music, friends, sports, food. Again, that would lend credibility to the real DID interpretation. If you consider all the world, though, almost all the reports of DID come from just 3 specific countries: US, Canada, and Turkey. So that would, and there's clearly been torture all over the world, unfortunately, severe child abuse all over the world. So that might suggest that it's not a real disorder. But there is things called culture-bound illnesses. So that would support the opposite viewpoint, that it is a real disorder, but it's just culture-bound. It is in the DSM-3 and later, which would support the idea, since the DSM is based heavily on research and experts in the different fields and specific disorders. That would give you credence of the idea that it is a real disorder. But then again, why such a late appearance of 1980? So that might take away from its reality of a legitimate disorder. And many clinicians, for example, with the link I have attached, questions its legitimacy. So there's evidence supporting it being a real disorder, other evidence supporting the idea that it's accidentally or intentionally created, and some bits of evidence can be used to either support either side. So I'll let you decide, because there is no correct answer to this particular question that this slide centers on. So let's consider treatment of the various dissociative disorders. Not surprisingly, given the acceptance of the psychodynamic viewpoint, especially in previous DSMs, that psychodynamic therapy of a short-term nature is often very successful. The person often resorts to use of the alters during times of stress, so coping skills are also very advantageous to teach. Hypnosis, again, what we said about hypnosis, but hypnosis is often used. And sometimes medication during therapy, the quote-unquote truth serums, some of the anti-anxiety drugs. For the depersonalization/derealization disorders, CBT, especially coping skills, antidepressants, often useful. And this disorder may or may not remit on its own. Dissociative amnesia almost always remits spontaneously on its own. And now we'll be on to our next chapter.